All right, let's jump right in. We're going to break down a model that is totally shaking up how we think about healthcare delivery. It's called the Primary Care Behavioral Health Model, or PCBH for short.
So, here's the game plan. First, we're going to bust a huge myth about what this is. Then, we'll talk about the new identity clinicians have to take on. We'll see what it looks like day to day, how success is measured completely differently. And finally, we'll get to the real heart of it, the long-term human connection.
So when you picture getting behavioral health support at your doctor's office, what exactly comes to mind?
For most of us, we imagine a classic therapist who just happens to have an office down the hall. But the PCBH model, yeah, that's a whole different ballgame. It's something fundamentally different. And this comparison just lays it all out perfectly. Look, co-located care is basically having two separate services under one roof. But with integrated PCBH, the behavioral health consultant, or BHC, isn't a visitor. They are a core member of the primary care team, working on demand with short, flexible visits, focusing not just on a diagnosis, but on the whole person.
Now, making that kind of integration work isn't just about rearranging the office furniture. It requires a really profound shift in how the clinician sees themselves.
And that shift is all about adopting what's called a primary care mindset. This is huge. It means you stop seeing yourself as a behavioral health expert who's just visiting a clinic, and you start seeing yourself as a primary care provider who happens to specialize in behavior. Your whole mission becomes the mission of primary care.
You know, Dr. Stacy Ugbaid puts it so powerfully here. It's often about unlearning what you were taught in traditional therapy training. The old rules of 50-minute hours and long diagnostic explorations, they just don't fit. It's a complete reboot of your professional identity. So what does this new identity actually look like in practice? You know, when the rubber meets the road. What's the secret sauce?
Well, if you ask the primary care providers, the PCPs, they'll tell you the it factor is this almost tangible excitement. It's a, yes, I'll see your patient and I'll see him right now attitude. It's not about being the smartest person in the room. It's about being the most available, helpful member of the team.
And the engine that powers all this is the warm handoff. The moment a PCP spots a need, a page goes out and a BHC responds in literally a minute or two and heads straight to that exam room. This isn't a referral for next week. It's immediate help right when the patient is there and ready to talk.
Once they're in the room, the BHC's #1 tool isn't some diagnostic manual. It's what's called the contextual interview. The whole goal is to quickly get a sense of what's going on in this person's world, often by looking at 3 areas: love, work, and play. The idea is simple. A person's struggles almost always make sense once you understand their context.
Okay, so what's so cool is how this micro-level one-on-one work connects to a much bigger goal. The PCBH model isn't just about managing a small caseload of individual therapy clients.
No, the real goal is to impact the health of the entire clinic population. And to do that, you need incredible reach. Get this. Mature PCBH programs can have a meaningful clinical interaction with up to 1/3 of all patients in the clinic in a single year. That's a scale that traditional therapy just can't even dream of.
So if the goal is different, you have to measure success differently, right? Forget counting billable hours. The things that really matter here are your penetration rate, how much of the population you're actually reaching, and your team's satisfaction. Are you making their jobs easier? Are you being a good partner?
And this quote from Dr. David Bauman just nails the mindset. It's this fundamental shift to caring about every single patient in the practice, not just the ones who happen to be on your schedule for that day.
This focus on the whole population brings us to our final point, and honestly, it might be the most misunderstood piece of the entire PCBH model.
You see, for decades, research has shown something pretty wild. Across all kinds of settings, the most common number of therapy sessions anyone attends is just 1. And because of this, a lot of people have looked at PCBH and just labeled it brief therapy. But that completely misses the point. It misses the whole picture. PCBH isn't about being brief. It's about being part of primary care's mission to provide continuous, longitudinal care across a person's entire life.
Think about it like this. A patient might see their BHC for some anxiety in year 1, learn a new skill, and feel better. Then, maybe they don't see them again for a couple of years, until a new life challenge hits, a tough medical diagnosis, a loss in the family, and they can immediately pop in for a tune-up. The BHC doesn't discharge patients, because primary care doesn't discharge patients. The relationship is for life. That consultant is always there, a trusted part of their healthcare team, ready to step in whenever they're needed,
for whatever comes next.
This model really shows what becomes possible when we stop putting care in different boxes and just start treating the whole person as a person for their whole life. It really makes you wonder, what if this became the standard instead of the exception?